morning, good afternoon, good evening, depending on where you are. I hope you had a wonderful weekend, and welcome to one of our webinars. This time, we're going to be speaking about testing dynamics. And for us to be able to delve into testing dynamics, again, COVID-19 and testing dynamics. My name is Kilian Songwe, and I work with the Global Healthcare Foundation. Joining me today is Dennis Bairugaba from Makerere University. He will be taking us into some of the testing methods that are used and how they compare and the challenges that they have. But just to be able to get started, again, one of the things we're doing with all of the work that we're doing and presenting of the webinars is actually trying to take the standard, give you the standard that all of this work is based on, and the standard basis that we're using. In this case, it's ISO of 189/2012, and we're going to specifically be looking at the Post 5.5, which is the examination processes. And with that introduction, Dennis will come from there about the different testing methods and how they compare and the challenges that go with them. So just to talk about standards, the Technical Committee 212, actually clinical laboratory testing and in vitro diagnostic test systems. This particular technical committee is working on over 57 different standards that cover all the things in clinical laboratory testing and in vitro diagnostic testing. So there are 57 different standards that cover all areas that you can think of. And I just purposely highlighting, there is the one that we're familiar with. I chose to start with that one. That's the ISO 5189, the 2012 standard. And then in that particular class of standards, that's the 15,000 standard. There is also the 15,194 standard, which also deals with in vitro diagnostics. But because we're going to be talking about molecular diagnostics, I just chose to show you this. This is just 4 standards out of the 57 different standards that the Technical Committee 212 is actually working on to be able to ensure that there is a standard that covers almost everything that we're doing in vitro diagnosis and medical laboratory technologies. So just going on to talk specifically about ISO 5189, the 2012 edition, and specifically about the examination processes, which is clause 5.5 in that standard. It looks at the area of selection, verification, and validation of examination procedures. So what exactly is this? When you're talking about selection, verification, and validation of examination procedures, we're looking at ensuring that examination procedures have been validated for their intended use. So we want to ensure the fact that that particular validation of verification process actually fulfills the use for which it is going to be used. So for example, you're not going to validate a test examination for the use of urine, and then actually when it gets to using it in the lab, you use it with saliva. If you know that saliva is going to be the element that is going to be used, then you want to be able to ensure that your validation and verification process is for that intended use, which will be saliva and not urine. So, when we look at validation of examination procedures, there are 4 very important elements around validation of examination procedures. The first one being they have to be, if they are non-standard methods. What does non-standard method mean? It's a method that has not been published, and it's not one that is commonly used or known. Then there has to be a validation, because that's a method that you're using in your own laboratory, for your own laboratories, for the intended use of your laboratory. It's very important that I raise this at this point, because a lot of the test kits that are out there for COVID or SARS-CoV-2 testing are actually still using the emergency authorization only. So at this point, we still have to do a lot of validation of these test kits in our different locations before we can use them. The second point here is laboratory design or development. If this is a home brew kit, there are a number of countries right now that are working on rapid detection kits. There is Ghana, there is Senegal, there is Uganda, there is South Africa, there is Kenya, a number of the countries on the African continent that are trying to develop kits. So these are kits that certainly need to be validated because they are homegrown in terms of their location of production and in terms of the development of the kit. Then validation, of course, needs to happen for standard methods used out of their intended scope. So there are well over 374 different test kits that are out there for testing for COVID today. However, they're very specific about how you're going to use them, whether you're going to use them as laminar flow test kits, or you're going to use them as serological test kits, or you're going to use them for a polymerase chain reaction test. If you change the actual element of collection, in the case of serological testing, that's going to be blood. If you decided not to use blood and you decided to use saliva, for example, then that is going to be using the test kit out of its intended use. So there needs to be another validation that will be done for you to be able to say, the test kit was developed to be used for blood, however, I'm using it for saliva, and I can still get the same results. Then validated methods subsequently modified. Yes, at this particular point, because we're still collecting a lot of data around COVID-19, there are a lot of very ingenious, innovative methods that are going on at different laboratories across the world, testing and trying different things from a research point of view and also from a diagnostic point of view. And so if there is going to be any change in what the manufacturer has said or stipulated in their kits on how to use, then again we have to be able to do a validation at this point to be able to use that kit. So I've spoken about validation and verification. But basically what we're looking at when we talk about validation is specific requirements for the intended use of the examination have to be fulfilled. We need to be able to ensure that the performance characteristics are actually attained when we talk about validation. So looking at the verification, I throw this up because there is just two simple words that actually change a lot of the meaning that is going on there. In verification, it says the laboratory shall document the procedure used for verification and record the results obtained. Staff with appropriate, and I highlight the word appropriate, authority shall review verification results and record the reviews. But look at what it says when we go over to looking at validation. It says the laboratory shall document the procedure used for the validation. Same phrase until you get to the word validation, and record the results obtained. Now this is where it becomes interesting. It says staff with the authority. In verification, it says staff with the appropriate authority shall review the validation results and record the reviews. So in very basic look at, in verification there is appropriate authority, which means that you have actually had the right training by the manufacturer to become the appropriate authority. Whereas in validation, because this is homegrown, you just need to be able to have the competencies in doing the testing in your facility. Moving on, measurement uncertainty is an area that actually has a huge ramification on results when we give them out. Today, the COVID-19 test is actually a qualitative test. And so people might ask, so what's the use of measurement uncertainty in a qualitative test? However, there is great use, because from the point where the sample gets into the lab, from the pre-analytical stage is when you're receiving the sample in the lab, there are actual pipette measurements, and we're talking about very small microliters of sample that is being collected. So those associated with the actual measurement processes, there needs to be a measurement that is calculated around the actual measurement processes. And I put in the ISO there is the ISO 20914. That's a whole standard that deals with measurement uncertainty. Again, just to be able to ensure the fact that in spite of the fact that the COVID-19 test is a qualitative test, it's going to say you're negative or positive, there are measurement processes in that process which needs to be looked into. So again, just looking at measurement uncertainty, it says where the examinations include a measurement step, but do not report a measured quantitative value, and that's a clear case with COVID-19. We still need to do we still need to calculate the uncertainty of measurement for all the pipette stages that are involved, because they could have a huge influence on the reported result. So, biological reference and clinical decision values. With the case of COVID, it's the clinical decision values that are critical. So we have today a lot of scenarios where people have tested positive and they've quickly disputed the fact that they're positive for one business reason or another, and they've decided to repeat their test, and then, yes, they've actually gotten a negative result later on. And this actually deals with the clinical decision values. And my colleague Dennis is going to look into some of the comparabilities and challenges that go on around here. But different platforms have different sensitivities. And with the different sensitivities, there has been so much talk about the CT values. The different CT values on the different platforms would actually be a good reason for why you would have a positive result. And if you took it to, another platform, you would actually get a different result. So those are things that have to be looked into very carefully. And as a result, these are some of the things that we want to be able to look at today. And we want to be able to ascertain what values do we get on what platforms, and what are the challenges we have for using these different platforms. So clinical decision values are pretty important when we are talking about qualitative results and what the actual cutoff is for those different results. Then at this point, then there is documentation of examination procedures. Documentation of examination procedures is key. We need, each laboratory has to document the procedures it's using so that a lot of the labs that are doing COVID testing these days are doing 1, 2, or 2, 3 shifts. They're actually working 24 hours a day. And if the labs are going to work 24 hours a day, it becomes really crucial that the labs are able, the different technicians, technologies that are doing the test, are able to perform the test the exact same way every time they do it. And that's the whole idea behind standards. The whole idea behind standards is the fact that standards allow for you to be able to carry out the activity in the exact same way every time the activity is carried out. And so documentation of examination procedures becomes very crucial, ensuring that if somebody came into work at 8 o'clock, or they came into work at 4 o'clock, or they came into work at midnight, that they were going to do the test in the exact same way, thus yielding reliable results that could be, that the organization or the laboratory could stand by at all times. So from that point, let me take this opportunity to call in Dennis to take us through some of the different methods that are out there for testing and some of the challenges and comparabilities that exist within the platform. Hi, Dennis. I'm going to stop sharing so that you could you could come up now. I think I stopped sharing there. Dennis, can you hear me?
Yes, I hear you.
Okay.
Good afternoon, everybody, and good afternoon, listeners. My name is Dennis. I will take you through a couple of issues related to COVID testing. As Kirian has mentioned, I will share my slides shortly. So I will take you through this presentation that is focused on the dynamics of COVID-19 testing. And we will be looking at some of the current testing technologies and discuss briefly some of the challenges associated with these testing technologies so that together we can work towards having an efficient system where we can all be confident of the tests that come from the lab. Kirian has very well discussed the standards that are required for this testing. So I'll be mentioning some of these so that we can go together. But before I proceed, we all know that SARS is one of the other several coronaviruses that have been affecting humans, particularly the severe types, the SARS-CoV, the MERS, and the current pandemic strains. But we also know that we have the mild respiratory ones that have been circulating all over the world. And here we present the different types, the CoV229, the NL, the HK, the OC43, and these others. So the diagnostic methods must be able to differentiate between all these different human coronaviruses so that you come up with a specific diagnostic that is specific for SARS-CoV-2, which is the current subject for our discussion. Now, the primary goal of the epidemic containment of COVID is to reduce the infection transmission in the population by reducing the number of susceptible persons or by reducing the basic reproductive number. And we know that the reproductive number is modulated by several factors, including the duration of viral shedding, the infectiousness of the organism, and the contact matrix between infected and susceptible persons. Now, due to lack of effective vaccines or treatments, the only available method to reduce SARS-CoV-2 transmission is by identifying and isolating infected patients who are contagious and can transmit the disease. And this is largely based on being able to effectively identify those persons through diagnostic testing, and then they can be isolated. All other measures can be put in place. If you look at the strategies for the detection of COVID-19, you must be able to deploy the appropriate tests basing on the kind of stage at which the infection is, if it is in the early phase, if it is in the later phase, and then you can focus your test on the either detecting the virus itself by looking at either the nucleic acid or by looking at the nucleocapsid protein. And there are tests that will be looking at these different parts of the virus. Or you can focus on the immune responses that have been generated as a result of infection. Now, the deployment of COVID-19 diagnostic testing has been varied across the world because of the different targets and also the purpose for which these are done. In South Korea, they deployed quite heavy testing that actually helped them to be able to identify the sick patients and ultimately be able to put in place containment measures that help them to bring down the transmission. And there are several tests that can be used at different stages, as I mentioned. These could be largely classified according to the target, but also according to whether they are going for the protein, as I mentioned, or whether they are going for the nucleic acid. The most common one is the reverse transcriptase or real-time PCR that targets the viral nucleic acid. And this can give you a product or a result within 3-4 hours. And when we talk about the result within 3 to 4 hours, this is the results that you get in the lab when you receive the sample and you have started processing the sample. But the time for you to collect the sample, transport it to the lab, process the sample and have it run and generate the result and get this result back to the patient could take between 2 days to, I don't know, probably depending on the circumstances, could even take much longer. So the RT-PCR targets normally takes up nasopharyngeal swabs or sputum or bronchial lavages, and all these can be tested on the RT-PCR. The LAMP or the loop-mediated amplification system is a modification of the normal amplification system, but does not use the the thermocycling that we are used to, where you vary the temperatures. And this is much easier to undertake and could also be used at the point of care. And this also takes up the same samples, but could run for less time, but takes much less samples because of the current LAMP platforms. The other methods are based on detection of the antigen that is part of the virus protein, or they are based on detection of the immune response that has been generated as a result of infection. And this could be through enzyme-linked immunosorbent assays, or they could be by rapid lateral flow techniques, which can be deployed at the point of care. And these are normally rapid. Within 15 to 20 minutes, you are able to have a result. Going further, this is a picture that I used in my previous presentation, but it's very, very critical as long as you are looking at testing. And you need to look at the time of infection versus the time when you develop clinical symptoms. And you have that incubation period where you do not, there could be methods that you could use during that angle or showing symptoms. Then you have the virus have peak viral replication. You are able to have or to use those nucleic acid detection or virus detection methods that would give you maximum detection. And after about 8 or 10 days, that's when your immune response is able to respond and begin generating immune responses. And once you begin developing antibodies, then you can be able to deploy those antibody detection methods. And therefore, the type of test you use will depend on the period of infection. And should you use any other method outside of the most appropriate period, then you are likely going to get false negatives, as we shall be talking about, either false negatives or plenty of testing errors. Now, testing errors in these different methods mostly are classified broadly into pre-analytical errors, all analytical errors, or post-analytical errors. And the pre-analytical errors are associated with misidentification of the patient or the sample. They could be associated with collection of an inappropriate or insufficient sample, or the timing of the swab, or the swabbing practices itself. There is a specific way that you put your swab in the nose, turn it around a couple of times so that you are able to touch the nares and pick the sample. If you don't do that, then you are likely going to get some errors. It could also be associated with a number of enzymes, particularly the RNases that normally degrade the nucleic acid. And by the time you get to the lab, you only have stuff that does not produce a very good result. They could also be associated with inaccurate conditions of sample transportation and storage, such as prolonged transportation time and injury or exposure. It could be associated with the presence of interfering substances or be associated with procedural issues occurring during sample preparation, such as pipetting errors, particularly when you have manual sample preparation or aliquoting. But you could also have cross-contamination or sample mismatch that is going to result into errors and affect your final interpretation of your samples. Now, although analytical errors, so this is the kind of errors that you're likely to get during the different periods of detection. And again, I shared this slide, but it's very critical to inform some of the challenges that we currently get in diagnostics for COVID, particularly with the false negative samples, as well as the false positive samples in either side, where you have, when you still have infection onset or the symptoms haven't set in, you have very minimal nucleic acid, and there is no immune response, you are likely going to get a lot of false negatives because there is no antibody, the virus is very little, and therefore you will have very many people that are turning out negative, but actually they have the disease and it is still developing. When you go beyond 16 days post-infection or post-expression of symptoms, then the virus is coming down, and during that period and beyond, you're likely again to get negative nucleic acid tests, because again the virus has dwindled, and therefore the best test to use at that time is the use of antibody detection, or that's the best serology diagnostic window when the patients have had infection for more than 14 days. The analytical errors, they could also be associated with non-adequately validated assays. They could also be associated with undetected failure or quality control, or active viral recombination, or testing that has been carried outside the diagnostic window, as I've told you, or poor harmonization of primers or probes, and non-specific RT-PCR. There has been quite a lot of challenges with regard to comparability of different testing methods. And these could also be associated with the poor harmonization of primers and probes that are associated with the current evolution of the virus, where some of the primers or probes are targeting genes or sections of the genome which is constantly mutating. And therefore, some laboratories are using those primers that were initially identified at the beginning of the pandemic. Since December, this virus has evolved, and they are still using those primers. And if there are potential mutations in those genes, then you are likely going to have a little bit of differences in the detection of those viruses that have evolved. And therefore, we need to be on the lookout, compare our current primers with the current viruses that are circulating within our regions, so that we can keep ahead of the virus and be able to optimize the primers and probes for the current circulating viruses at any one particular time. The other errors could be associated with non-specific RT-PCR annealing, which again could be associated with the evolution of the virus, and therefore the primers that some of the people may use may not be very current. Most of the post-analytical errors are usually associated with the way you process your results, the transcription errors, how you obtain your results from the testing machine, enter them into the results dispatch or results management system, and how you ultimately print out your results and pass them on to your clients. And those may be minimized if you have a very good system, but they may still occur. I just wanted to show you how the evolution of molecular tests has come. You have the end point where you only observe the results at the end. This is typical of conventional PCR, where you put your master mix and your sample, you time your thermocycling for up to 3 hours, and you can go and sleep until you come back only to check the result. And you are not able to make an interpretation of the result until the end. For the real-time PCR, you can monitor your reaction. You have your extraction, and then the amplification and detection is real-time, and therefore you are able to detect the result as it goes on. And once you begin going into the thresholds where you have the virus multiplying sufficiently to be detected, then you can already begin looking at your positive samples. The next generation, the point of care first generation, which reduces the time significantly. But the latest technology is where you combine both the extraction, the amplification, and the detection, so that you are able to shorten the period when you are able to report on your results. Now, most of these molecular tests target different sections of the genome. You've had people testing for the N, like the CDC test that tests different sections of the nucleoprotein gene. There are those that target the E gene or the envelope gene. There are those that target the spike gene, and others that target the different other areas, particularly the ORF1A and the ORF1B. Again, as I mentioned earlier, different platforms or different protocols target different sections of these genes. And therefore, it is wrong for platforms that focus or target different genes to be compared. Yes, they can be compared, but then you will have challenges depending on the sensitivity of that particular gene and the rate of mutation, as well as the threshold of when you will start getting your positives coming up. So there have been these challenges related to different platforms, for example, the Abbott or the Tuckman tests. And what we see is that there needs to be a recommendation on identification of the most sensitive of these methods that can be able to break the tie that of those methods that are discrepant. And therefore, many countries will have to assess the different types of platforms that are being used in their countries, and where possible, identify positives and negatives that have come up of each platform and compare them on the different platforms so that we can have a testing algorithm that is going to serve the different countries basing on what they have. However, there have been a couple of studies that have already compared these platforms. Some may be available in your countries, others may not. And these have been able to relate the sensitivity of the different platforms and make recommendations, and also the limits of detection or the LODs for each of these methods, so that once you are using a test and it is negative and it is tested by different platform and comes out positive, then you understand why these discrepancies are coming about and you have an idea how you can resolve them. So you, for example, have got these different tests. We shared this last time. So you have, for example, the test that was developed by the Yip et al. That was focusing on the NSP2, while the Chan et al., the Chinese one, was focusing on the helicase, and this actually, the RDP helicase test, has been shown to be one of the most sensitive tests currently available. And therefore, if you compare it with the original CDC and probably also the current Berlin protocol, there are slight differences that have been observed when you compare the positive agreement and the negative agreement tests. There are some variations, and you need to be very well aware of these so that then you can be able to resolve them when they occur, as long as you have appropriate internal controls and all your equipment and other assays have been validated. Going on, this lists again some of the methods that we talked about last time, again giving you a little bit of details about the sensitivities, the limit of detection, as well as other concentrations of materials that you use, and whether they are limited by the platform or whether you need specific reagents. And again, out there in the field, you'll find that different testing labs have got different equipment that may not necessarily match with some of the reagents that are available. And because of the limitations of the current commodities, sometimes it's a little bit of a challenge when people want to switch reagents and try them on different platforms. And that can be a little bit of a problem and also cause some challenges in the kind of results that you obtain. And these have been reported in several changes in different platforms when you switch different reagents to different platforms. Now, recently there have been a move to identify point of care molecular assays. Fortunately, there are a few that are coming up into the market, and most of these utilize isothermal nucleic acid amplification techniques, just like the AMP, and some of these are bench-top based, while others actually handheld instruments. And probably in future, possibly these are going to become more common. And of course, some of these are very common to you, like the GeneXpert. Unfortunately, some of them, of course, are not readily available because of the global demand. But as we go forward, probably the production is going to increase, and these are going to become increasingly available, and they can be utilized, and they need to be validated before use in each country. In addition, there are new developments of modern technologies. I guess most of you are very much conversant with the CRISP technology, also the gold nanotechnology, as well as the magnetic resonance and the surface enhanced Raman scattering, which are modern technologies that make the testing much easier and can be better automated than what is currently pertaining. So once, thank you very much. And this is a topic that we can discuss very, very many times and compare notes, particularly for those who are on the bench and are working with these methodologies on a daily basis. But it's important to note, as I've mentioned, the key points here, that there are different platforms out there. They use different recommendations for reagents. Their limit of detections are different, and these need to be acknowledged so that you know the limitations of your test, and you also know how to resolve those when they occur, particularly when you have different platforms in the country and you know which platforms in your country are more sensitive, and therefore you can be able to refer your samples to a more sensitive platform whenever you have presumptive tests that you are not sure of. So thank you very much. Keep safe, and please make sure you social distance to minimize transmission of COVID. Thank you. Over to you, Kilian.
Hi, Dennis. Thank you so much indeed. Just before I go back to what we were talking about, I think you raised some really important points, and you touched on some things that we see as we go across the continent. But again, it's really important. I go back to the issue of standards. Each lab that is doing testing has to actually have very clear standard operating procedures. Because what those procedures do is they ensure that the activities happen in the same way every time, all the time. But I think one of the other bigger things that you touch on is the issue of different platforms and the limit of detection for the different platforms, because that actually is going to be able to into determining, as you rightly said, is going to be able to take us to be able to determine the right algorithm for use in our different countries, depending on the commodities that are also available on the platforms that we have in the different countries. I recognize the fact that all the different areas are commodity constrained. These are things that from a public health perspective, there needs to be a clear understanding so that people know how they can test and they can be sure about what their results are. So at this point, I'll just stop and see if we have any questions for either myself or for Dennis. Please This is the time to raise your hand or just go on and start screaming. Okay, I think there is a question there. Let's see what I have. This is from Hengi James. How can Africa manage the COVID-19 pandemic with such limited PCR testing? Is there a way of implementing some kind of symptomatic approach for COVID? And the next one is South Africa seems to be one of the few that is doing the joint screening for COVID-19, TB, HIV. Where is this? And do you think more countries should use this model? Dennis, could you jump in on this?
Yeah, thank you very much, Kilian. How can Africa manage the COVID pandemic with such limited PCR testing? Yes, this is a very, very big question. And we have to take it head on. Now, as I mentioned, there are different testing technologies. One is symptomatic for clinicians, basing on the case definition for COVID. And unfortunately, this is good enough when patients are showing symptoms. But we know that over 80% of the people that actually are positive for COVID are not showing symptoms. So leaving these 80% untested means that you have people out there not showing symptoms and they are transmitting infection. That is a tragic kind of situation that we are likely going to have. However, given the limitation of resources, we may have to find a testing strategy basing on the resources available, basing on the commodities available, basing on the facilities that are available for testing, and have different testing capabilities. The best option that everybody has been on everybody's mind is using rapid diagnostic tests. Unfortunately, as we have seen, most of the rapid diagnostic tests are either detecting the antigen, which is the viral protein, or they are detecting the antibody that has come up as a result of immune response. And these two normally come a little bit late when the patients are already showing symptoms. And therefore, we've got to make a balance between the resources available and what strategy we are going to use, because we can't certainly do what we cannot afford. That is a bare fact, and there's nothing that we can do about it. So the other question about South Africa using, doing COVID testing for TB and HIV, again, the same thing. We know that there is TB, there is HIV, and at least those two still have funding under Global Fund and other programs that are still making sure that they are tested. It doesn't necessarily mean that if you have TB or HIV, then necessarily you have COVID, no. But there are chances that if you have TB and HIV, probably your immune system might be compromised to the extent that you are more vulnerable to COVID-19. And therefore, the clinician should be able to make that assessment and where possible, decide whether you need a COVID testing or you do not need a COVID testing. If resources were available, then that would be okay to test everybody that is coming in with HIV, with TB and other comorbidities, which have been shown actually to be a very big problem, or they actually make the COVID cases worse, including diabetes, as well as heart-related conditions that are associated with most of the mortalities. Kirian?
Yes, Dennis. Yeah, there is another question just right after that. I was going to let you to take that as well. This is still from James.
Yeah, so given the massive increase in cases in Europe, the death rate seems to be remaining disproportionately low in Africa as compared to Europe. Is this due to the limited testing capacity or better clinical outcomes? This is a question that everybody is asking, whether our brothers and sisters are immune or whether there are other factors. So far, we have not seen any genetic advantage of Africans being more immune or being more resistant to the SARS-CoV-2. I think my take is that it's just the difference in the stage at which we are, and we are seeing many more cases coming up. But one of the facts that we also know is that the virus does not survive under UV light. And that probably could potentially make a difference between the temperate regions in the north and the tropical regions in Africa, where you have a lot of virus on surfaces under temperate regions that can easily be picked up by anybody that touches them. Whereas in the tropical regions, if you a positive person touched the surface and that surface was exposed to sunshine or UV light, then the viral load decreases and therefore the potential infectiousness of that virus is diminished. But also particularly because we live in more or less self-isolation. If you go to our villages where there's a potential isolation of everybody in their gardens, in different places, that could also potentially play a role. Unlike in the temperate regions, again, where in winter, everybody is caged into their houses, everybody is together, that could also potentially explain. But as I mentioned, we are yet to see how this pandemic is going to develop in Africa. We have seen serious cases in South Africa where they have winter, but in these countries also, we are seeing, for example, what is taking place in Kenya, in other countries, and it's just time that will tell us whether actually there is a potential difference between all these factors that we have mentioned. Thank you, Kirian.
Thank you. Thank you, Nick. I'm going to call on Bright. Bright?
Yes, Prof. Can you hear me?
Loud and clear.
Okay, good afternoon, Prof. Thank you very much. Thank you to Prof. Dennis. You know, I just wanted
Bright, you're muted.
Can you hear me now?
Yes, please.
Okay, all right. Okay, Prof. Yes. Prof. Dennis, thank you so much for sharing these dynamics on the COVID testing diagnostics. Now, I just want to put something into perspective. Now that some of the African countries are slowly beginning to open the airports, one of the measures that are being put in place has to do with this testing on arrival. However, we know that testing is not only just processing of the specimen. In fact, it starts from this collection of the specimen. So my concern is that you have a jet arriving with 300, 400 people, and all these have to go through testing. And I'm using my country, Ghana, though I'm not in Ghana at the moment, as an example. You have to go through that process of swabbing and taking the specimen and testing before you exit the arrival hall. The issue I'm concerned about is the protocols for specimen collection, because we know these are molecular specimens, and cross-contamination from just one person to the other can give somebody a false, a positive result when actually they are not positive. So I just wanted to know if there is any current protocols that are in place for, specimen collection that can be standardized across board, that can be shared as benchmarking, so that at least some precautionary measures can be taken to avoid this sort of cross-contamination. Thank you. Over.
Thank you very much for that very, very interesting question, because Uganda is just about to open the airports in the next couple of weeks. And there's been a lot of discussions as how best to undertake sample collection and avoid these potential contaminations. It's a very big challenge having to collect samples from 300 people who are inpatient. They have been on the jet for quite a number of hours. And yes, there is a huge potential for cross-contamination. The avoidance of contamination normally relies on the behavior of the persons that are collecting these samples. We have been to a couple of places, we have made some observations about this, and it's a very big challenge. There is also some kind of lag that sets in when people get tired. But also what we have observed is that travelers, for this matter, sometimes also don't like to be swabbed, particularly for the nasopharyngeal swab. And certainly there are some who actually have said, no, you can't take my nasopharyngeal swabs. And yet studies have actually shown that nasopharyngeal swabs are more sensitive than the oral swabs, but also the way the healthcare workers will be taking off these samples is also very, very critical. So I totally agree. There's going to be a very big challenge. And there is no alternative protocol. The protocols for sample collection are the same. There have been suggestions and studies that have looked at the use of saliva, voluntary saliva, which would have been optimal. But again, the sensitivity is still very limited. Probably if we get more sensitive platforms that can optimize the use of saliva, that would be the best. And we are hoping that probably this can come up sooner than later, so that these can be deployed in such kind of settings where you have people arriving and traveling and congregated in a small area. The other option would be to deploy as many healthcare workers as possible, and also create sufficient room where these samples can be taken off. In the interim, there is no any other standard method for sample collection that could potentially alleviate this problem, apart from the healthcare behavior and being careful to be able to avoid as much contamination as possible. Kirian, you might want to add a few comments on this.
Thank you, Dennis, for those points. Yes, the issue of people arriving, 300 plus people arriving on a flight and trying to collect samples from them, it's going to be a very tricky one. And it doesn't matter whether you are arriving at any of the African ports of entry or in Europe or Asia, wherever it is. I think that whole idea of knowing that it's either going to be nasopharyngeal or oropharyngeal swabs that is going to provide you with the best result makes it very challenging. But again, I think this is one of the things that travelers are going to have to get used to in the next coming months. As soon as they get onto the plane, they're going to have to be welcomed with what the landing procedures are and what the access to the different countries are going to look like upon arrival, so that they start getting used to it. There is truly no way around it. But the hope is as we go into more months, and most probably the first 12 months of COVID, right now there is talk of using saliva. There are studies around that. And as long as we can continue to do some more innovative testing and see what other specimens we could collect and how quickly we could collect them, there is a strong chance that we might be able to reduce on that pressure at the airport. But again, all the countries are going to have to beef up their healthcare capacities at their points of entries to be able to receive these huge numbers. And again, there is no restriction as to when the planes can come in and how many of them can come in. So again, that's going to have to mean that the healthcare capacities at the points of entries have to increase. They're going to have to be 24 hours. We're going to have to think about burnout. We're going to have to think about counseling for these healthcare workers, just to be able to ensure that we can sustain the kind of volumes that the different points of entries are going to have. But yes, Bright, that's going to be an issue that we're going to have to continue working on as we go into the many more months and hopefully not years that are ahead of us and COVID-19. Well,
yeah, Prof, this is Thomas. I hope we still have 1 minute to listen to this question. Hello, can you hear me?
Yes, Thomas, I can hear you.
Okay, thank you. I just wanted to know, Professor Dennis, whether could you comment on the distribution, if any known historical distribution of SARS-CoV variants in Uganda and possibly East African region, if you have that data? And also in one slide, you mentioned the very nice, you showed a very nice slide about the NAT window, the period where we are likely to get a true result for any nucleic acid amplification tests. And then when you were talking about the analytical, pre-analytical, and post-analytical errors, you indicated that sampling outside the NAT window is actually an analytical error. I need some clarification of that. On that, I thought it would be a pre-analytical error. Thank you.
Thank you. I think I confirm your last comment. That should be a pre-analytical error, but that impacts on the outcome of the NAT test. So I think that's where the confusion is. The historical variance of the strains within the country and the region, you recall that we started with imported strains, which reflected the places where the positives had visited. So we had, for example, strains from Europe, strains from the US, strains from China, that exactly resembled the places where the contacts had traveled. However, as we got more and more community transmission, this picture is going to change, because then we are going to have internal virus interaction, as well as mutations within the viruses locally. And when we obtain more sequences and these are analyzed, then certainly we'll be able to see more variances that are particular to the region or to the country because of the internal transmission and the internal mutations within the viruses internally. I guess within the limited time, I've answered your question, Thomas.
Thank you, Dennis. My sincere appreciation to everybody who joined us today. Again, we never want to come to an end with one of these without continuing to make the recommendation. One of the biggest things that we can do to ensure that we are able to control COVID-19 is compliance. We can continue to wash our hands with soap, running water, sanitize as often as possible, and use a face mask. And use of face mask be also really important is to continue to keep a social distance so that there is no transmissions. Again, I thank you very much indeed for joining us today. you could certainly reach us by one of the following ways. You could give us a call or drop us an email, join us on Facebook. We're right here in Uganda, in the Kololo area. So if you want to visit with us and talk with the standards and issues around COVID, we'll be very glad to have you. Till then, have a wonderful week. Enjoy yourself. See you same time, same place next week.